Must be.
Okay, you can start.
Hello? Can everyone
Yes,
hear me?
go ahead. We can hear you.
Okay. Good afternoon, everyone. Today we'll be presenting the topic, motivational interviewing. I'm Carlota Sejokwane, and our other two presenters are Nakisa Kuma and Rochelle Toy. So what is motivational interviewing and what is its purpose? The practice was originally described over 20 years ago and was later tailored and modified to what we know it to be now. It's formally defined as a directive, client-centered counseling style for eliciting behavior change by helping clients to explore and resolve ambivalence. In much simpler terms, it's a way of guiding someone to bring out or draw out change by encouraging them to look into and settle clashing feelings or thoughts about things. The purpose of this is to help individuals identify areas in their lives that could potentially benefit from change and supporting them to overcome barriers that actually prevent them from achieving this desired outcome, while also acknowledging conflicting beliefs or feelings that they may have. Where does it come from, you may ask? Motivational interviewing originated in 1983 by an American clinical psychologist, William Richard Miller. He realized quite early in his career that when counseling patients struggling with substance abuse, specifically alcoholism, the most effective treatment was often more active and empathetic, like brief interviewing and motivational enhancements, while the least effective were passive, like films, lectures, or confrontation. So we pioneered this therapeutic approach. He later teamed up with a South African psychologist, Stefan Rolnick, in the early 1990s to co-write a book on techniques practiced in motivational interviewing. So while this intervention strategy was originally used in the treatment of alcoholism, it was later developed and seen as useful in the prevention and treatment of lifestyle conditions, such as diabetes, eating disorders, etc. The principles. There are 5 central principles to MI we need to look at. The first, express empathy. This principle is key to motivational interviewing. It requires one to use reflective listening while communicating respect and support for your patient. Establish a safe and open environment to help the patient believe that ambivalence is completely normal. Acceptance facilitates change. The second, develop discrepancy. In this principle, it's the health professional's job to magnify the difference between the patient's current behavior and their goals in order to allow the patient to present an argument for change by raising awareness of the negative consequences surrounding problem behavior. The third, avoid argument. Trying to convince your patient that a problem exists or that they need to change could result in more resistance. This can rapidly result in a power struggle and does not enhance motivation. The goal is to walk with the individual, not drag them. The fourth, rolling with resistance. Resistance is almost inevitable, however, should not be opposed, but rather acknowledged and explored. Resistance is an indication that there's a need to change strategies or listen more carefully. And lastly, the fifth, support self-efficacy. This principle focuses on building confidence in your patients to believe that they will find solutions to the problems they identify and will be responsible for the method of bringing about change. This is a critical component of behavioral change, so it's crucial that you as a health practitioner also believe in your patient's capacity to reach their goals. Nakisa will be taking over from here.
There are multiple trainable MI techniques that are described by Rolnick and Miller. The use of the FRAMES acronym is an application of MI techniques and is used for effective brief interviews. This acronym therefore provides a useful way to remember techniques in a consultation. The FRAMES technique is therefore the focus of our discussion for MI techniques. F stands for feedback. The act of constructive, non-judgmental feedback of the patient's behavior based on information from structured and objective assessments is very useful. Give feedback on the risks and negative consequence of behavior, and then seek the patient's reaction and listen. Delivery should be respectful, straightforward, easy to understand, and culturally appropriate. One should practice reflective listening and an empathetic style during feedback. R stands for responsibility. Emphasize the individual's responsibility for making his or her own decision about the discussed behavior. This role is active rather than passive in both the choosing of the treatment as well as carrying it out. A stands for advice giving. Prior to giving advice, the patient should be asked for permission to talk about the behavior as well as giving the advice. Advice should be simple, not overwhelming, and match the patient's level of understanding and readiness, as well as match the urgency of the situation and his or her culture. We should not tell the patients what to do, but rather suggest. The approach may be either directive, where in the form of making a suggestion, or educational in the form of explanation. M stands for menu for change. Give menu of options to choose from and for the patient's involvement in the decision-making. This may be in the form of choices regarding their treatment goals, as well as the type of services needed. E stands for an empathetic style. Be empathetic, respectful, and non-judgmental. In order to display empathy, this usually entails reflective listening, the act of listening and comprehending back to the patient what has been heard in order to ensure that they feel heard and what you heard is correct. S stands for self-efficacy. Self-efficacy is one's ability to produce a desired result or effect. In this technique, the role of the healthcare professional is to encourage the patient to believe that they will be able to make the change possible. Express optimism that the patient may be able to modify their behavior. We now move to a podcast of Dr. Toy's anatomy, where we will be in Dr. Toy's consultation room at the local CHC. A 20-year-old has presented for consultation. Here we will demonstrate some of the techniques discussed, focusing on those as part of the FRAMES acronym.
Please come inside, have a seat. How are you doing today?
I'm doing all right, Doc. Just haven't been feeling myself for a while now.
What can I help you with?
Well, I've been feeling so very weak lately. Weak, tired, and really cold as well.
I'm having a look at your weight from today. You weigh 38 kgs. Does that surprise you?
Not really. Well, Doc, to be honest, my mother's the one that's been worrying about me and kept nagging me to do something. So I came here.
Your mother's concerned about your health.
Yeah, she says I'm too thin. She keeps crying and saying that my heart's one day going to stop.
Have you noticed any health difficulties that suggest there may be grounds for concerns? For example, can you tell me about your periods?
And to think of it, I haven't had them in a year or so. Listen, doctors have told me about my anorexia before, and I'll say now what I've always said. I'm not prepared to let my weight go above 40 kgs.
Why is that?
Because even though I know I don't feel well, this is all I've known for so long. It's how I cope with everything.
I hear you. We tend to stick to what feels safe. It's a survival instinct that usually serves us pretty well until it doesn't. The beginning of your healing is going to be a lot of you wrestling your brain that has primed you to experience food as dangerous. It feels safer to avoid. Am I making sense?
I think you kind of are.
You're terrified about what will happen if you start to attend to your nutritional needs. And you know that there are clear signs that your body is suffering right now. For example, your blood sugar is running at a dangerously low level and your bones are continuing to break down. Where do you think you'll be in 5 years if you continue?
I don't know. I want to change, but I don't know where to start. I can't just eat. I can't decide to do it when I don't feel hungry. I can't even remember what it's like to be full. How much is too much food? How much is too little? It's honestly terrifying to see food differently to how I see it now.
Look, we don't have to have it all figured out today, but you telling me that you see the need for change is incredibly brave and more than enough. Let's take it day to day together.
From the podcast, we can see several of the MI principles being demonstrated by Dr. Toy. Through reflective listening, we see the use of feedback in a sophisticated manner. Dr. Toy is comprehending the patient's history and feeding back in a constructive manner. Throughout this podcast, the principle of empathy is demonstrated through the doctor's reflective style, respectful and non-judgmental responses. The doctor ends with an encouragement and an optimistic statement. This demonstrates the principle of self-efficacy. These techniques may be used at various points and repeated during the consultation. Also note that all these techniques may not be used in every consultation. Motivational interviewing is effective in smoking cessation, medication compliance, diabetes management, AIDS risk reduction, eating disorders, dietary changes, substance abuse, and other behaviors. But does it work? Yes. According to Rubach, Sandberg, Lorenz, and Chisterson, 80% of studies reviewed in a systematic review and meta-analysis study showed that motivational interviewing is effective in changing patients' behaviors. It also shows that it outperforms traditional advice.
MI misconceptions. In order to ensure that this approach is carried out in the highest quality, not only do we need to know what it is, but we need to be clear about what it is not. 1. MI is not a way of tricking people into doing what they don't want to do. MI is not autonomy from them. If there's no inherent motivation to change, MI will not manufacture it. 2. MI is not a form of CBT. CBT generally presumes that the patient lacks something, whether it be new coping skills, learning new behaviors, etc. However, MI is a brief conversation in which we elicit that which is already there, not teaching new skills, new conditioning, or re-educating. 3. MI is not just client-centered counseling. Although there are similarities to the traditional client-centered approach, MI is about being consciously goal-orientated, about having intentional direction to change. 4. MI is not a panacea. MI is not used to address any and all issues that presents itself to the health professional. Those who already have the motivation to change do not need MI. Studies have shown that using MI in areas where a health professional has no business tipping the balance one way or the other has actually caused more harm than good, hence why it is used in certain areas only. The South African context and limitations. 1. Time constraints. Due to the high patient load and being understaffed, consultations are limited. 2. Language barriers. MI is best done when the patient understands in their home language. 3. Cultures. One has to be cognizant of all the different cultures we have in our country that could potentially lead to certain limitations. Just to highlight a few of them, we must be aware of different roles in families, how traditional practices influence our patients' behaviors. We must be aware that not everyone is fortunate enough to have an extensive background in health literacy. For many people, they were brought up in a type of culture where self-reflection does not come easily. Expressing one's fears and desires may be particularly challenging to them. I think an important one to mention is also the gang community and pop culture that also plays a big role in our society. For some, drugs and alcohol is a rite of passage in their life. In terms of pop culture, we have all seen the impacts on society, specifically young teenage females with regard to eating disorders. 4. Privacy. There aren't private rooms in the places we work, specifically the ED. 5. Lack of training. MI is a relatively new phenomenon. Although it is incorporated into most university training programs, it's still a work in progress and the training varies. 6. Follow-up. This limits us on 2 levels. 1. When we are seeing patients in areas where follow-up isn't necessarily included in the plan, even though they may require MI. 2. Some patients have lost to follow-up in the system, whether at a clinic or a hospital. 7. Finances. Generally, if you are seeing a doctor in private, you're more likely to get MI at the time of consultations, purely on the basis that the above limitations are not usually a problem, i.e. you're more likely to see a doctor who speaks your language, consultation times are longer, there's privacy, etc. So the take-home messages are, MI is useful in areas where there's resistance to change. MI works if done in the right setting. South Africa has limitations to MI, and we must be cognitive about these solutions. How to solve these limitations, and these are references in our case. Thank you.
Thank you very much. I think that just want to make a comment that all of you guys, your presentations are super. Thank you very much. Put an effort into it. The learning itself isn't the fact that you are putting this together. You're providing some very useful insights. I hope that the discussion afterward also helps you. So let me just share a few comments about it. And if there are any questions from any of you, please pick up your hand and we can allow you a chance to get some reflections from the team presenting. A lot of my understanding of motivational interviewing is what not to do. So in other words, when you raise the problem of time, it is often a false one. The real challenge in motivational interviewing is to have a good relationship with the patient and not to confront or to judge the patient. And these are things that are, you assume a relationship is there. It's kind of a big problem. Many people don't pay attention. They don't listen very well. They don't reflect well. So these are things that you should be doing, irrespective of MI. You should be doing this, but you need to do it better. Then MI is and that's part of MI. But what's the other part of MI that's the second part I said, is don't confront. And that's about not challenging the patient when they share with you an attitude that suggests they are not keen to change. Now, in some ways, that doesn't mean you back off. But if a patient is not willing to change, if they're willing to change, you ask them about their problem and how they view their problem or their behavior and whether they feel the need to change, if it's not clear enough, then you're obviously going to give them advice. You're giving them information. But in primary care, even that is time consuming for you to give advice. You should actually be saying, listen, you're very interested. Let me actually get my nurse to give you information. Here's paper, here's a group, you refer. You as a doctor have much better things to do, but you want to make sure they get addressed. But you don't need to do it yourself. So time's not an issue. The third thing, which is very important, and I think it's part of this, is that you need to ask directed questions. Once you've established where this person is in terms of their stages of change, if it is that they are resistant to change, they're pre-contemplative, they don't even see that they have a problem, you're going to have great difficulty. And you pick that up quickly, you're going to have to say, well, let me just build a relationship and focus on that. Think through when they would think it's a problem, and that's this kind of goal-oriented approach. So you're not just being patient-centered, but you're trying to get them, not you, to build up goals. But you might have to help them by building up options, saying, well, if you were to consider coughing as a problem, if you're a person with chronic cough, or in this patient, if you were to lose weight, more weight, or when would you think it's a problem? Let the patient respond. Oh, if I have to lose too much weight, or if I have to get sick, or if I have to land up in hospital. So shall we see, do you think that would represent a problem? Get them to concretize it. So this is the goal orientation to it. So to me, the real thing that is required in MI is don't give advice, talk by asking questions. And if they need advice, get other people to give advice. So that scenario that was painted, there's far too much advice giving, in my view. You need to be careful of that. And I was not sure in that podcast whether this person was actually saw that they have a problem. Pre-contemplative is they don't see they have a problem. Contemplative is still, I have a problem, but I'm not sure whether I should do anything about it. That's contemplative. And you have to see, well, okay, where are they? They're only in a stage where, you start dishing out advice is when they're saying, no, I want action. I want to do something. I'm not just contemplating this. I'm not just thinking it's a problem. I've decided I'm going to do something about it. Any other thoughts? Any other comments? And as I think has been mentioned, empathy is a very strong part of that relationship between the patient and the doctor. And empathy is not just the reflectiveness. I mean, a question to the group that presented, Rachel, do you think that you felt Dr. Toy actually put herself in the shoes of this patient? Because that's what it means. Do you want to respond to that? And then we'll go to Kerry. Thanks, Kerry. Rachel? Or is it Rochelle? Rochelle, you want to respond to that? All right, Kerry, go ahead. Yep, Rochelle, Rachel, is it Rachel or Rochelle? Is it Rachel or Rochelle?
Rochelle.
Rochelle. Well, what do you think? Did you think that Dr. Toy was empathetic, which is putting herself in the shoes of the patient? Did you see any statement that made you feel, no, she's putting herself in my shoes?
Prof, I think at certain points there was times she was putting herself in the patient's shoes, such as when in the beginning of the consultation, when she was reflecting on what the patient was saying as to whether the problem is something that they were coming in with, and asking whether it was their mother's concern. However, there were points in the interview where she could have possibly been more empathetic, and maybe listened to the patient rather than giving advice.
Okay. Empathy, remember, is putting yourself in your shoe. Think about what you want from your friend when she's going to be empathetic, and put herself in your shoes. You say, I hate food. I can't handle it or I don't like being fat. Is it something you would say, yes, I hate being fat too?
No.
That's the kind of statement, and you'd be surprised. We feel like that is approving of the patient's behavior, and it's not.
Just not.
We are all very discomforted by that kind of thing. Tasneem, I'm going to mute you. So be aware that that doesn't need to be compromising by you saying, I don't want to be fat too. I don't think it's nice to be fat. Do you think that is, and that doesn't mean you end the conversation there, but is that, not being fat in your case, is that something that's good? How do you weigh that up against your health? Get them to reflect on the question, but point out problems. Kerry, point out the conflict, the thing you pointed out. What about the fact that not gaining weight is actually make you unhealthy? Is that something, how do you feel about that? So you want to show the contradictions, the ambivalences. Kerry, go ahead.
Sorry, I just wanted to ask, just in terms of our setting, I just find it incredibly difficult because we basically see our patients once. And
Yes.
so to try and develop this relationship with people literally on a one-time basis is so
Yes.
difficult.
Absolutely. No, listen, let me be very clear. Even though as family medicine, we are operating in the public service, we're not teaching you to function only in the public service. We want you to be aware of the challenges in the public service, but we are hoping either you'll help create a better environment in the public service, or you'll work in the private sector where you can shape it yourself. We're teaching you to practice medicine irrespective of the setting. Of course, I'm aware that yes, private sector can be challenging, but that doesn't mean you can't practice certain good things. Like, for example, if you have motivational interviewing, yes, I might not be able to tell the patient to come back to me always, but in many circumstances in a community health center, you could tell them, listen, I'm going to be here, come back next month and come and see if you can't find me next time. Or tell the person you'd like to see me. You'd be surprised. They'd wait a few minutes longer if they could tell the nurse at the front desk that, listen, doctor said I must come and see her. And they might say, all right, wait there. And then when she's free, you can go in there. So don't underestimate the possibilities of having continuity of care. Privacy is a problem you should be pointing out. There's no ways you should be functioning without privacy. Time is a challenge. But many a times, I mean, you look at your own performance in the public service. I mean, by 1 o'clock, everything's gone off. Everybody's gone away. It's like the clinics close at 1 o'clock. That doesn't mean that we don't have time. It's just the way which the culture of the public service is. We cram everybody into 4 hours from 9 to 1. And that's not good because you're not working for 4 hours. But that's the public service culture. You can do differently. Even in the public service, you can say, no, I want to give care that's appropriate. And so think about it. I know the public service isn't easy to work in, but it's not impossible to try and practice good medicine. Okay, I know it's challenging. Hope that answers your question, Kerry.
Yes, thank you.
All right. Good. No comments other than that. Thanks, Kerry. I think that was a useful comment. Any other comments from anybody else? If not, we can just stop it here. I'll just stop this recording.